Aidan, I want to thank you for joining us. You have had a very busy schedule. On Sunday, Aidan flew in from Doha. I think you arrived late Sunday evening to join us on Monday. But in Doha, there was a meeting with the health leadership of Afghanistan, Pakistan, the polio leadership of Afghanistan and Pakistan, and some independent experts on polio eradication. Can you give us a sense of what those discussions were all about and perhaps a way forward in those two countries?
So thanks, Carol. And at the outset, a very big thank you to all of the Rotarians for all that you have done and continue to do for polio eradication. The purpose of the meeting, of bringing the full country teams together, is a recognition that just two countries remain to interrupt wild polio virus transmission. These countries are different and distinct. Both are sovereign. One has a population of 250 million. The other has a population of more than 40 million. They share a common border of 2,640 kilometers, across which there are millions of people traveling every year. And I think what is important to simply underpin is neither country can succeed alone. Both countries can only succeed when they both do it at the same time. So it's not either or. It has to be both together. What was the purpose of the discussion? You've heard from Bill, there was 12 cases of wild polio virus last year. We have just 5 cases of wild polio virus to date this year. But what we're... Whoops.
Okay, clap for that.
What we have to focus on is what the virus is telling us. The cases don't tell us what the virus is doing. The environmental surveillance, which is the testing of wastewater, of sewage, is actually telling us that there is extremely low-level transmission taking place. We need to have a common shared understanding of what that means, so that not one country or the other, what's happening in this narrow strip both sides of the border. The second focus is missed children. So we have vaccinated millions of children across the board. But what we're doing is increasingly granular, not provincial, not district, not sub-district, not even union council, down to small hamlets and villages to see where those gaps are. Because those gaps are the key to closing the border, or closing transmission across the board. And again, what we want to make sure is that the virus, for those who are familiar with Liam Donaldson, the polio virus survival guide relies on the human factor. It relies on humans not working together because the virus respects no borders, either internally or cross-border. We have to work together to make sure that common risk assessment, but that common targeting of where missed children are, Kandahar, Quetta, Paktika, North Waziristan, Peshawar, Jalalabad, we need to know, both in the reservoirs and in between, that every single child is being reached. And I'm pleased to report that good progress, renewed energy to make sure that we're able to finish that job.
Thank you. It sounds like, the program is really zeroing in on those very particular places where the virus still circulates. And I think it's interesting that, although countries don't always agree on everything, that countries like Afghanistan and Pakistan can come together around a joint goal of eradicating polio. So that's exciting. So we're not only working in Afghanistan and Pakistan, the two remaining endemic countries, we're also active in many countries in Africa. Can you tell us a little bit about what we're doing in Africa and why?
Thanks, Carol. You will recall that Africa was certified wild polio virus free in 2020. But you also heard again from Bill that as long as we have transmission anywhere, potentially everywhere is at risk. That nightmare came through in early 2022 when we had an importation of wild polio virus originating from Pakistan, which ended up initially in Malawi, followed by Mozambique. Within 72 hours, we had boots on the ground. Within 30 days, the immunization response started, initially in Malawi and Mozambique, subsequently into the neighboring countries of Zambia, Zimbabwe, and Tanzania. That outbreak, the last case we saw, was in August 2022. That outbreak was formally closed earlier this month when we were fully satisfied that there has been no trace of the wild polio virus re-established anywhere in the African continent in the intervening 2 years. So, really good progress. But why do we have to continue to work in Africa? We need to make sure that we have sensitive surveillance, so there is no missed transmission of anything that's coming. We also need to make sure that children everywhere across the African continent continue to be vaccinated, so we build population immunity. What we do not want to have is to finish in Afghanistan and Pakistan and have to come back and fill gaps elsewhere. So the pressure is on. We continue to work in more than 30 countries. So again, there's no weak chinks in our defense to allow the virus to take our advantage of. Not easy, not straightforward, but absolutely essential to finish the job.
Thank you. So we're immunizing hundreds of millions of children every year. We have an extensive surveillance system around the world. And this has brought down cases of polio by more than 99.9%. But this infrastructure has also contributed to other health priorities and emergencies, actually. Can you tell us a little bit about the other diseases that this health infrastructure has helped address?
So, for polio eradication, it's a global initiative. And it's geared to make sure that we're able to reach each and every child, no matter where you are in the world. Which means that we're able to deploy people, funding, vaccines, cold chain, to make sure vaccines turn into vaccination where they're needed the most. When we look at how we engage and support more broadly, I will zoom in on 3 specific topics. The first is surveillance. Surveillance allows us to identify and assess risk. When our frontline surveillance officers visit communities, visit health facilities, visit hospitals, they're not just reporting back on polio. They're reporting back on measles, they're reporting back on diphtheria. All of this information comes back to help inform risk assessment and planning in terms of how we manage the response. We support the movement of samples from field locations back to laboratories because we have all of this infrastructure already in place. I think the second area that I would highlight is something that people might consider very simple: microplanning. Microplanning is really understanding where is every child within a country, where are the children located. If we go back to Malawi and Mozambique, what we found is that from our initial campaigns in both countries, we were missing more than 30% of the children because they were not on the registers for essential immunization. So what polio does is that it goes down to every local village, make sure that we're able to identify each and every child so that not just for polio, but for essential immunization going forward, we're able to reach these children. And then last but not least, we conducted more than 800 million immunizations across the globe last year. We used that opportunity to introduce other antigens. Measles is probably the best, but it has included a range of others. We also add soap, we add nutrition, we add a whole range of things to address what communities at greatest risk need the most. So it is a critical infrastructure, not just for polio, but for public health and emergencies at large.
Yeah, thank you. I think it's heartening to hear that our investments in polio eradication go far beyond polio immunization. And it is a good demonstration, like Tayaba at the Resource Center providing additional services, is it globally we're providing additional services as well. So I'll ask you the same question that I ended with Tayaba. We have Rotarians from around the world here with us today who will soon be going back to their homes, to their clubs, their districts. What message do you have for them?
So thanks for this. And I think this is a really important opportunity, again, to thank you, but to say simply this. Poliovirus has been with us since ancient times, for millennia. Millennia. We had visionaries in Rotary back in 1985 who made a promise that every child everywhere would be protected from this disease. We've heard that we've gone from 350,000 cases a year down to handfuls of cases in endemic countries. There have been enormous gains. There are 20 million people walking and living healthy lives today because of the interventions. But this program wasn't set up just to deliver that. Zero means zero. We're on the threshold of doing something enormous, but we don't want to remain on the threshold. We want to cross the threshold. You have run a marathon. We're kind of getting very, very close to the end, and it's hard. Pakistan and Afghanistan are not easy. When people talked about India, they said it was impossible until it became possible. People said Nigeria was impossible until it became possible. And people will be saying the same thing about Afghanistan and Pakistan, that the impossible becomes possible. Thank you.
Well, thank you, Aidan. Aidan will be with us the rest of the day and then hopping on a plane to Geneva to attend the World Health Assembly first thing tomorrow morning. I want to thank you for taking the time to join us here. And please give another warm applause for Aidan and the work that he does in polio eradication.